Good morning, I'm Kwangsun Park, an orthopedic surgeon from Seoul. Today I will discuss myofascial pain syndrome through neuromyofascial release. My first message is simple. The painful spot is not always the pain generator. This is the local twitch response we often see during shockwave treatment. Traditionally, we call it a muscle phenomenon. But it may also point to a mechanical stress zone at the fascia-nerve interface. Before chasing the trigger point, a painful point may be only a symptom. The mechanism may be loss of gliding among fascia, nerves, vessels, and movement. That is the entrance to neuromyofascial release. Why are some MPS patients not cured? First, the concept is too narrow. Muscle only. Second, the origin of overstrain is missed. Third, the wrong layer is treated. So we must move from point chasing to interface thinking. Sometimes the trigger point is not the real problem. It is the overloaded place. When we correct postural asymmetry and reduce chronic fascial strain, shock wave, manual therapy, and exercise can work better. This is my own case. For years, I had chronic neck and low back discomfort. Correcting pelvic imbalance changed my symptoms. The lesson is clear. Correct the driver before releasing the interface. Technical failure does not always mean poor technique. Even good ESWT can fail if the true target is superficial fascia, deep fascia, a nerve branch, or a vessel-related autonomic interface. This is not a rejection of trigger points. It is an expansion. Travel taught us muscle trigger points. Stecco taught fascia and CC points. Luke hydrodissection taught nerve branches. And finally, NMR, neuromyofascial release, is the model I emphasize. It integrates trigger points, fascial densification, nerve tree thinking, and interface gliding into one clinical reasoning framework. In short, treat the interface, not just the point. Fascia is not wrapping paper. It is a sensory and mechanical organ. It contains nociceptors and mechanoreceptors. Hyaluronan allows layers to glide. When sliding is lost, pain and stiffness can appear. This ultrasound image reminds us that fascia is a sliding system. Healthy layers move smoothly. In chronic pain, this motion can become restricted. The treatment goal is to restore gliding. The FLUSH study gives useful clinical numbers. Deep fascia, superficial fascia, and muscle can all contribute to myofascial pain. One tender point is not always one structure. The question is, which layer dominates today? Now comes the missing link. Pain may live in the branches. Small sensory nerves pierce fascia, branch, exit bony canals, and cross firm surfaces. When fascia loses gliding, nerves lose freedom. I define neuromyofascial release as restoring gliding at the nerve-fascia vessel interface. The goal is not stronger pressure. It is more precise interface release. Release fascia, free nerve, restore movement. For physical therapists, the algorithm is practical. Verify the painful movement. palpate CC, CF, and Valaix points. Build an interface hypothesis. Release the interface, then retest and retrain. Now let's move from concept to clinic. Familiar pain patterns can be re-examined as interface problems. I will show two examples: medial elbow pain and groin pain. For medial elbow pain, two CC points are important: the distal medial intermuscular septum and the FCU tendon area. These points can overlap with possible ulnar nerve entrapment. Palpation verification completes the picture. Pain while wringing out a cloth often reveals this pattern. If familiar pain is reproduced, think beyond tendon. Consider the CC point and nerve interface. This case shows painful loss of elbow motion after trauma in a 53-year-old woman. After treating the interface, we retest immediately. Movement tells us whether the target was right. This is a 34-year-old woman with pain in the side squatting position. After ESWT to selected CC points, the patient changed immediately. That suggests an interface level driver. From this case, two problematic directions become clear: hip flexion and external rotation. For hip flexion, consider the iliopsoas fascia. For external rotation, consider the gluteus medius fascia. My final message is simple. MPS is not only a muscle disorder. Pain often emerges where fascia loses gliding and nerves lose freedom. Trigger point is the sign. Neurofascial gliding loss may be the mechanism. Thank you for listening. I welcome your questions and clinical opinions. I hope this lecture gives you a new lens for recurrent myofascial pain. Find the interface, free the nerve, and restore movement.